we're moving directly into the next panel, which is the culmination of the panel day before Senator Whitehouse comes to address us. And in this panel, since we're in DC, what better way to finish today than talking about what can DC people like yourselves do to help in some of the regulatory flexibilities, some of the legislative sorts of things that we've heard about. So as the team is coming up here, I see Kim is here, Brian is just about ready. We're coming along, and Greg has the clicker. So leading this panel is Gregory Daniel. Greg, as you know, is from the Duke Margolis Center, which has been a true leader in thinking through the issues and how policy changes can help enable and facilitate what's going on in this space. And both he and Marianne, who works with him, have been huge collaborators and supporters and partners with us at MIT New Digs and FoCUS. So Gregory, off to you.
All right, thanks, Mark. And thanks for inviting me to a very important topic. And we've been talking about sort of how to pay for curative therapies all day long. And it was exciting to see on the last panel some actual pilots being put into place in the state of Massachusetts, as well as some federal pilots as well. So we thought this particular panel could maybe further that discussion and start getting to more solutions, ideas that we're seeing out there that are overcoming some of the barriers, but also comments from this panel too on sort of additional ways to either scale these pilots or make sure that they can be implemented going further. So to kick this off, I'm going to first provide a few background slides for the panelists to react to. I can tell it's not a Duke event.
And we would like to thank Gregory Daniel very much for his facilitation. Greg, it's been wonderful.
Yeah, that's right. You had two senators here, so that's very good. Just to provide a few background slides, we heard value-based payment arrangements mentioned a couple of times earlier today. Senator Cassidy listed it as his second prong in his three-prong approach. Late last year, the Trump administration put forth its blueprint on how to deal with drug prices and competition, and value-based payment arrangements were a big part of that too. And so I thought I'd kick off with just a brief overview of sort of like, why are people talking about value-based payment arrangements, and what are some of the benefits? And first and foremost, they are designed to better align payers, manufacturers, and providers to some extent, if they're included in the arrangements, towards better outcomes and value, and not focusing on volume and restriction of access. So the idea of designing payments that are tied to outcomes that matter to patients, outcomes that matter to payers, meaningful things that we want to make sure that if we're paying high prices for some of this innovation, that we're tying those payments to the actual outcomes that matter. Another important aspect of this is that it can, in some ways, reduce the uncertainty that payers have. So if they're faced with, a really high price, but we're not quite sure. We're not sure if this technology is going to benefit my members. We're not sure if the duration of clinical benefit is going to extend beyond what we saw in clinical trials. So the idea of tying payment to outcomes is a way to reduce some of that uncertainty on the payer side, and hopefully, perhaps, improve the access that patients would have. Another important aspect in this, and all of these sort of go beyond just curative therapies, but any time a value-based payment arrangement is designed, is that they can actually also involve providers. And not particularly for rare diseases, but for a lot of our chronic diseases, providers are increasingly going at risk, as Michael Sherman highlighted in the earlier session. And the opportunity to design value-based payment arrangements for medical products that align and support provider value-based payment arrangements, so that if providers are going at risk for particular outcomes, perhaps manufacturers can also go at risk for some of those outcomes, so we can align the outcomes that we're really looking at and bring the providers, the manufacturers, and the payers to the table inside an agreement. These arrangements can also support better real-world data collection and real-world evidence generation. So if we're tying the payments to, it's easy to tie, not easy, but efficient to tie things to claims data, but oftentimes the measures that we really want aren't in claims data. And perhaps these arrangements can open the opportunity for manufacturers, payers, and providers to actually work together to design the actual collection that would facilitate those arrangements. And then also, so if we're trying to move away from volume-based payments and design these value-based payment arrangements, it actually opens the opportunity to then think about, okay, so then what are the innovative payment mechanisms within that? So paying over time, subscription models, for example, that we heard earlier today, or other innovative ways to actually make sure that the payment arrangements are aligned with what really matters to the patients and to the healthcare system. So clearly, a promising value-based payment approach is paying over time and as the therapy continues to show clinical benefit. And you can see I didn't say whether this was a 4-year or a 5-year contract. I just said 20% up front and the remaining 80% are at-risk payments. You can calculate how many years that might be. But we heard in a number of the panels that there are significant barriers. On the legal and regulatory side, Medicaid best price is a significant issue. We're going to dig into that a little bit more on this panel. The federal anti-kickback statute and concerns about violating that. Concerns about whether or not the outcomes that would be in a value-based payment arrangement are in the label, and if they're not, would the companies be at risk for violating what they're permitted to talk about? And then certainly for gene therapies where you have really high prices but a small patient population, what are specific state issues that tend to be barriers? On the operational side, most likely gene therapies and curative therapies are going to be physician-administered products, either in the inpatient setting or in the outpatient setting. For Medicare, that usually means that, and for commercial, that we have buy and bill, where either the hospital is purchasing the technology ahead of time or the provider group is purchasing, and the reimbursement is either via a DRG with potentially an NTAP. The challenge is the DRG plus an NTAP typically won't necessarily cover all of the costs that the hospital might be at risk for in the first couple of years if it's inpatient. If it's outpatient, the concern typically has been the provider markup. And within the Medicare program, you'd see like the reimbursement to the provider would be the actual average selling price plus 6%, and 6% on top of a $1 million treatment is a significant provider markup. But oftentimes on the commercial side, we see markups much larger than 6%. So we're talking about ASP plus 200% or 300%, clearly not sustainable for these really high-priced technologies. And so the question is, for these technologies, how do we move away from buy and bill so that providers and hospital systems aren't going at risk for the initial purchase of the technology? Other operational questions are around operationalizing the payment over time. We know patients are leaving health plans and changing health plans, and there are a lot of questions about how best to deal with that, or how best to deal with contract mobility and exchanging data after a patient might leave the particular health plan. So turning to some possible solutions that we've either seen in draft legislative proposals or other stakeholders have put forth. On the legislative side with regard to Medicaid best price, a couple of options have been just wholesale create a Medicaid best price safe harbor where the value-based payment arrangements are exempt from Medicaid best price reporting, as well as potentially creating value-based payment arrangement specific price reporting, where you might have a Medicaid best price for a particular product that's not involved in a value-based payment arrangement, but separate price reporting requirements when a value-based payment arrangement is in place. Another option on the legislative side, and we've heard this discussed earlier this morning about the potential for a pilot or demonstration pilot under CMMI to actually sort of exempt the pilot from Medicaid best price reporting and use that pilot to figure out what are better ways to calculate Medicaid best price and other price reporting requirements within the context of a pilot. On the administrative side, I'm not sure how much support there is for this, or whether or not these options are going to be better than the legislative options, but the ideas are where CMS on its own can either reinterpret the performance requirement that's within the bundled sales provision. Another idea was to modify the basis of measurement for Medicaid best price, which is like a unit price, typically a injection or a tablet, but in the context of value-based payment arrangement, the question is, what is a unit price when you're tying the payment to an outcome? And then an idea that of maybe new Medicaid best price calculations that can take into account the chances that there will be clinical failures over time. So you can do that prospectively by looking at clinical trial data and estimating, under a particular value-based payment arrangement, what's the likelihood of clinical failure, and under that arrangement, what would then be the price paid? Or to look at real-world evidence as data accumulates over the first couple of years, retrospectively look at what was the average price paid when you're averaging in clinical failures and not, and use that as a basis for what Medicaid best price might be. So a range of options there that we're gonna dive into a little bit more on this panel. In the interest of time, I'm not going to go too much into the federal anti-kickback statute or off-label communication. I will mention, since it came up several times on the off-label communication, that in June of last year, FDA Commissioner Scott Gottlieb released a couple of guidances that I think tends to address this issue. FDA recognizes the role of value-based payment arrangements, recognizes the fact that outcomes in those deals might not actually be in labeling, and provides guidance on how to navigate that. And so I'll ask a panel if they think that, if that seems to solve the concerns on that side. On the operational challenges, I do want to highlight doing things in Medicare often is different than doing things in the commercial side. So options for avoiding buy and bill on the Medicare side might be using a vendor specialty distributor, thereby allowing these provider payment options to, or allowing providers or hospitals not to go at risk by instituting a vendor that then the provider can receive the drug for, so that they're not actually taking title to the technology and therefore going at risk. The question always comes up, if you do that, if you take providers and hospitals out of buy and bill, what would be the appropriate reimbursement back to the provider for that? And so some ideas have been a flat or tiered fee back to the provider for their administration, but also having the technologies and the clinical capabilities for these high-risk drugs that are administered. It's actually a part of some of the Part B reforms that we're seeing from the administration under the IPI model as well. So the idea of moving away from buy and bill is being addressed, or at least being looked at outside of these technologies. And then, a big issue that we heard about is the sort of what happens, and this is more on the commercial side, when a member leaves a particular health plan. And as Michael Sherman at least summarized on the previous panel, that a couple of things can happen. If you can have a deal with the other payers so that that contract can actually transfer and that new payer can pick up the payments, but that may not necessarily be scalable across the country. And so other options would be that first payer who pays for the actual gene therapy might pay a fee when that patient leaves that might settle the tab, essentially. You pay the remainder that's due, or there might have been a negotiated fee to get out of the contract, or the first payer can continue to be responsible for the duration of that contract, even if the patient transfers to a different health plan. The only way that would work is if that original payer has an ability to get data back, so that it can continue to see if that technology is meeting the milestones that were agreed upon under the original contract. And then we heard a couple of times this idea of a reinsurance and how maybe a third-party risk pooling mechanism or the reinsurance structure might actually help here. So those are the topics that I want to go over on this particular panel. And I'll take a moment to introduce the panelists, and we'll dive right into, I guess, your reaction to all of those ideas. So first we have Kim Caldwell, who is principal at Texas Star Healthcare Consulting and formerly at Humana, formerly at CMS. Brian Carey is a partner at Foley-Hoag. Mehb Khoja is president and medical risk managers, and then Peter Saltonstall is the president and CEO of NORD, the National Organization for Rare Disorders. So first, let's talk about Medicaid best price. I think every single session prior to this one mentioned Medicaid best price, and everybody said that needs to be addressed. But I guess let's go to Brian initially. There have been a couple of ideas. I summarized a few of what some solutions to getting around Medicaid best price. From your perspective, what do you think is the most viable path forward?
Sure, and that's really the $64,000 question, I think, at any one of these events, and has come up throughout the day that the best price and the price reporting issues in general have created a lot of uncertainty for the manufacturers because they do carry civil monetary penalties for the companies. In order to participate in the Medicaid program, a manufacturer has to sign the rebate agreement, and they have to report pricing information to Medicare, which determines the amount of the rebate that the states get, and that includes the best price provision, which requires the manufacturer to report the lowest price that they make available to any wholesaler, retailer, provider, healthcare entity, or government entity. So the whole issue that everybody has been focused on is what really constitutes a sale and what constitutes a discount. And this is an area where with price reporting for best price and AMP in general, there hasn't been much guidance recently from CMS, but there hasn't been any guidance really on how this would apply to value-based arrangements. A number of stakeholders have gone to HHS and CMS over the past 3 or 4 years asking for guidance, and the most recent guidance that came out was in the summer of 2016, which just really restated the rule and said that best price is going to be determined based on the specific facts of the individual arrangements. But it did have language in it that talked about providers includes a hospital or other healthcare entities, and that best price would normally include the lowest price that they would be able to obtain a product at. So that gave a lot of manufacturers some pause. As Greg noted, I think there's really been 3 different avenues of focus. The first avenue is really looking at what type of guidance HHS could give through interpretation of the current regulations and either develop some type of safe harbor or enforcement discretion that when you're conditioning a sales price based on an individual health outcome metric for an individual patient, that falls outside of the best price reporting. I think there's been a couple of different arrangements for these types of value-based approaches. So there's the all or nothing money back guarantee, and in those cases the question is there really a sale if the provider never pays for it, or if the manufacturer never charges them? And then on the other hand, you have the approach that was just discussed on the last panel of payments over time, and in that case, where would you calculate what is the sales price? I think that the administration to date has been very supportive of saying we don't want to stand in the way of states and commercial payers negotiating these types of arrangements, but they have not taken the lead in providing guidance the way they have done at the FDA and what types of communications could be done with payers to facilitate value-based arrangements. So I think people are hopeful that as part of the larger initiative the administration has in drug pricing, that this would be one component of it, that they would come out with some type of interpretation. The other 2 approaches would be to do some type of demonstration program, some pilot that would involve both states and commercial payers as well as Medicaid, and as part of participation in that, there would be an exemption from best price. And then the third avenue really is what Senator Cassidy was alluding to earlier, that Senator Cassidy and Senator Warner have developed legislation that would specifically exempt out of the Section 1927, the Medicaid statute, and other price reporting requirements, value-based arrangements. And the one issue I think that HHS has been really looking at is whether the federal programs are getting the benefit of these value-based arrangements to the extent that states are participating in them and that these arrangements are being offered to the Medicaid programs. Do they really need to fall within the Medicare best price if the states are getting the benefit of it? Already, supplemental rebates that are made to states are excluded from best price reporting. So if these are structured as a supplemental rebate with a state, those rebates would be excluded from best price. And if similar arrangements were being made to commercial payers, then they'd really mirror the type of activity that's going on with the states. So I think the key part will be the extent to the Medicare participate in these type of arrangements going forward.
Yeah, so the good news is that CMS is engaged in this, congressional staff, and we've actually seen some discussion drafts released, as you pointed out. So people are working on this, and I think that from all of the interactions that I've seen, nobody is standing up and saying, no, we don't need to do that. Medicaid best price is fine the way it is, and we'll just keep it for these arrangements. I think by and large, most stakeholders who have weighed in on this issue agree that something has to change, and we're just trying to figure out the best path forward. And so that's
yeah, and I think that's why the activity of the MIT New Digs and other collaborations like this are really important to push the envelope. These are not situations where it's on the books today saying you cannot do this. It's never been done before, so there's uncertainty about how you would do it. But you now have states like Massachusetts and Oklahoma and Louisiana pushing the envelope, commercial payers like Harvard Pilgrim developing new models, and it's really going to take that type of activity to get the government to respond to it and provide more guidance about what is the permissible path forward.
So any other comments from the panel? Kim, do you want to weigh in on this?
Yeah. If I can, I want to remind everyone up front that I am no longer employed by anyone that is a public company. Therefore, I get to say what I want. I will tell you, one of the things that has been a hot button for me for the last decade or more is, I will tell you, I think that OBRA 90 has outlived its usefulness. In 1990, when OBRA 90 came out, it did two primary things that were really important. One, it caused pharmacies to have to share information on what the risk could be on medications. Two, it created Medicaid best price. Those were really important at the time. Today, pharmacists everywhere around the country burn down billions of trees. As they print out all the scare tactics of things that drugs could do that nobody reads, they throw it away, or they call the doctor and say, I'm not taking it because the paper says this. When there are digital ways we could give that same information, and I think that's something ought to change. Two, Medicaid best price really has not altered very much. There was a little change about 5 years ago, but what it hasn't changed is it didn't open up innovative views of looking at things. And I think we ought to redo the Medicaid best price so that it's not Medicaid gets best price, which means everyone else gets worse price, because that's really what it says. And if it's not that case, then we ought to still make sure that the Medicaid program gets basically the same type of rebates that they get today, something consistent with what's out there. That certainly should not change, but it also ought to allow some freedom of things that take place. So for example, there ought to be something that allows the value-based contracting or outcomes-based contract or performance-based contract, whatever you want to call it. And there ought to be something that protects the manufacturer so that a small sample size, something goes wrong, doesn't hurt them. It doesn't put them at risk as things are being calculated. There are probably 5 or 6 other things that it ought to do, but I think it's time that we together help the system redevise OBRA 90 so that we can modernize it like we're trying to modernize other things.
Thank you. So let me go to the other end of the panel. So Peter, one of the issues that I think comes up, and although we haven't heard much about it today, is at the individual state level, even within state Medicaid programs, are there challenges that patients have in terms of getting access if the Center of Excellence is not in their state, or if a particular state does sort of go into one of these more innovative access approaches? How does that affect patients?
I think that's a great question. And I want to sort of bring it back to the fact that I'm looking at this through the rare disease lens, if you will. So smaller populations and historically drugs that are slightly more expensive. And when you take that down to the state level right now, where there aren't consistent programs, one of the things we've heard today is that everything that we're working on here is building, and it's 5, 10 years away, that patients today are trying to get therapies at the state level from the Medicaid budgets. And what we're seeing, I can tell you at NORD right now, we are seeing constant shifts right now and barriers for patients unable to get their therapy. It's approved for FDA, in the formulary, expensive price, can't pay for it because we can't balance the budget, in essence. And so we are seeing lots of people actually move from state to state right now so they can get access to a therapy. And I think that it's an ongoing everyday issue for today, right now. While we're building these models, how do we make sure that we take care of the patients that are out there right now that need their therapies? And the Medicaid issue for us right now across the states is a major problem, I will tell you.
Yeah. Any other sort of thoughts from the panel on sort of state access issues?
When you put that up, I thought the very same thing about folks that are moving from state to state, because there are constitutional budgets and there are things that are put in place, and states are limiting some of these accesses. And when a Medicaid recipient has to move from one location to another to make sure that they get what's out there, then that creates a problem. On the other hand, the way the constitutions are, that does cause a balanced budget. That does somewhat limit it. And kind of jump ahead, if we will, on Medicaid, to me, I think probably when these are covered, that'll be all paid in 1 year, but the forward rolling rebates or whatever the concessions would be from the manufacturer probably ought to roll to that first year as well. Then there could be something that would balance if something goes wrong. But that way, at least it's accounted for in the particular budget year. Is it maybe a heavy hit? Maybe not so much over any given year, but if you're trying to add on additional payments, it may really be hard if you have now, over a period of time, assimilated a lot of patients that you have a portion of the payment coming due. It may be a multiplier effect that states have trouble balancing in their budgets.
Yeah.
Let me just say, I agree with you. I think it's a real issue, and I think that model may be something that we need to start to look at. But I think that rare disease patients, it seems to me right now, because it's higher price with very small populations, we're seeing that across lots of states right now. So this population seems to be more at risk right now because of the price-driven issues and because of trying to balance the budget. So it's an issue that we need to resolve, not in 10 years, but next week.
Right, and that's one that we haven't seen as much activity on in terms of what the legislative solution could be, or what other ideas are.
Can I also say to you, beyond Medicaid at the state level, if you're looking at commercial payers, we're also seeing various types of, I'll call them roadblocks, if you will, and different things put in place to transfer either coinsurance or step therapy or other things such as that make it harder for those patients to be able to get access. So it's not just Medicaid, it is beyond Medicaid at state levels right now.
Okay. So let's turn to sort of paying over time, these performance-based annuities, and this issue of when patients, particularly in the commercial sector, when patients leave health plans, what happens? What are different options to address that? Can the contract transfer? If not, can the data transfer back? And it seems like the Massachusetts pilot has worked this out to the extent that commercial payers who compete with each other in the same geography are willing to sort of get together and not violate antitrust, but get together and partner in a way that would benefit the patient, that gives the patient, in a lot of cases where this isn't worked out, the patient can feel, or the family, if it's a pediatric patient, can feel trapped to not change plans, because then what happens? And so seeing commercial payers sort of collaborate in a way that enables patients to continue to feel free to change jobs or change health plans is really good. But may not necessarily be scalable to all payers in the country. And so one of the questions that I have particularly for you, Mehb, is from the perspective that you come from with risk pooling and reinsurance, what are some sort of innovative ideas that you see as perhaps being more scalable?
So it's a really good question. I think a lot of the earlier panelists have acknowledged that the idea of annuitized payments in the self-insured employer segment could be very difficult. And so I guess I'll take the contrarian side here and say, I think the current system already works. And let me make my case for that. The commercial self-insured market where reinsurance is at play is probably about a $20 billion industry. The commercial fully insured space and the reinsurance component of that is probably another $20 to $30 billion industry. So you got a $50 billion industry that already covers durable treatments. Of that $50 billion, roughly 90% of that is medical related, and most of that medical expense is inpatient treatments. So something like a kidney transplant is a durable therapy. There's a lifetime of value to that. The charges associated with that could be $400,000 to $500,000, similar to the cost that we heard earlier today for things like some of the CAR T therapies. And so there is already high cost claims in this marketplace that are already covered with one-time payments. And I think that the current system works. When you think about some of these durable therapies having performance-based measures that could potentially reimburse if the treatment doesn't work down the road, there's got to be some synergies there between the manufacturer and the reinsurer, who should ultimately be reimbursed if they reimburse a charge that's no longer a charge 5, 6, 7 years down the road.
Yeah. So it is an interesting corollary to organ transplant or bone marrow transplant, where we see a one-time charge that seems to work out. Although in that case, there's, the cost is for the procedure. In this particular case, there's a procedure cost, which, for the most part, I think most payers and everybody agree, like, let's reimburse our provider systems for that procedure that they do. But the unique thing here is that there's also a technology that has some sort of guarantee associated or performance guarantee associated, and so that's separating out the provider payment to the technology payment, whereas in the organ transplant, we don't have that technology piece because we don't really pay for organs themselves. But what we can learn from that, and I think particularly in the reinsurance space, the stop loss, where for the fully insured population in a commercial setting, maybe this pilot works. But for Senator Whitehouse is here, so I'm going to go ahead and wrap up our session. I guess now, is that what you're, Mark? Okay. And I got everybody to talk on the panel, so I'm glad I got to everyone. And I think, if I can ask you guys are going to stay for a little while after Senator Whitehouse, so if anybody in the audience does have questions for our panelists, maybe see them after. So thanks for your time. Yeah.